Hi, good morning. First, let me start the video with a little apology. I was not able to complete the video on time, and so we got delayed by one day. If everything goes according to plan, you should see this video on the morning of Sunday. So, uh, I thought that since we were discussing retinoids for the past 4 or 5 weeks, it becomes very important to link drugs and diseases together. Okay, so if we study the pathomechanism of acne vulgaris, we'll be easily able to understand what is happening in the disease because we have touched upon the mechanism of action of different retinoids in the past. Okay, the way they act. Since we have a certain background of these drugs acting on the skin and acting on the pilosebaceous unit, now becomes a very good time to understand the pathomechanism of acne, and it the topic is very important if as far as residency is concerned, because it becomes a very important understanding. We need to develop an understanding how do acne starts from a microcomedon and become more inflammatory, presents as inflammatory papules, pustules, and sometimes simply comedonal acne. And if we have an understanding of the pathomechanism of acne, we can then understand how retinoids are going to help, or how should we think about using, let's say, antibiotics in acne, and when should we consider using anti-inflammatory drugs. Sometimes we do add steroids with retinoids, and so, what are these, separate conditions or separate indications for combining drugs? In order to understand that combinations, we need to know how does one single lesion of acne occur, and why is it that we have. I agree that retinoids are the mainstay of treatment of acne, but why do we have different other class of drugs also? So in this video, I'm not going to cover different class of drugs, but we'll focus on the pathomechanism of acne vulgaris. The way a pilosebaceous unit actually gets inflamed, leading to comedone and keratin, lack of expression of keratin. Uh, how does acne actually develop in an individual? And it will be easier for us to now understand the pathomechanism. And as far as the academics are concerned, this is a very important topic. You are frequently asked to write short notes on it. Okay, and if you go through this video, you can have a good holistic understanding of the pathomechanism of acne. So what I've done is I have utilized majorly four sources. I've covered Rook's ninth edition, Fitzpatrck ninth, Bologna fourth edition, and Andrews four textbooks, and some of the articles, 2 or 3 articles I've covered, so that I can create a somewhat of a good theory points regarding pathomechanism of acne. So without much further ado, I think we'll start with this video to learn about the pathomechanism of acne vulgaris. Okay, so now the definition of acne is it's a complex and multifactorial inflammatory disease of the pilosebaceous apparatus. So this is a somewhat of an arbitrary and somewhat of an umbrella term kind of a definition, because what essentially happens in acne is the inflammation of the pilosebaceous apparatus. That means hair and sebaceous gland. So there's an inflammation. It is complex and multifactorial. So not one factor is responsible. You have a lot of factors acting together to inflame the pilosebaceous unit. Now, as far as epidemiology is concerned, you have acne is now presenting earlier and they're lasting longer. So most of the time, we do have patients developing acne after 30 years of age, or patients who have started developing acne at the age of 10. So the duration of acne vulgaris is of course now spreading over to include a lot many years. And mostly it is said that because of earlier onset of puberty in children of nowadays, or as far as the generation is increasing, the onset of puberty is now earlier. So because of that, the development of acne also gets a bit shifted towards the earlier years. Normally, the age affected is about 10 to 13 years. Mostly young females are affected more as compared to young males. They have more inflammatory lesions, they have more difficult to treat lesions, they have more recurrences, they have more severity of disease in young females as compared to young males. The peak is seen in about 15 to 20 years of age. So severe persistent disease is more characteristically seen in females. So this is a diagram that I've taken from Rook's, if I remember correctly, and it just shows that the incidence is increasing and decreases with age, but the decrease is very slow as compared to the increase, and mostly it is in between 16 to 30 or 16 to 35 years of age. So that is how the epidemiology of acne is shifting over the years. Now this table is also taken from Rook, which implies uh, the bearing of different factors on severity of acne regarding the strength of evidences, so that we have certain idea what are the aggravating factors in acne vulgaris. So for that, many times patients will ask us that what should we avoid eating or not. So it's a good idea to tell them to take balanced diet and to avoid foods which are high in glycemic index. Now, what is glycemic index? Glycemic index is the property of a food, that how much it will lead to a sugar spike after oral intake. Okay, if a food leads to a very high sugar spike, then they have a high glycemic index, and vice versa for low glycemic index. Food products like ice creams, sugars, or desserts, these are food of high glycemic index. Additionally, milk and milk products, they have moderate evidence, so you can ask to avoid this, but you don't have to restrict it as such. Body mass index has a low strength of evidence. The other factors which have high strength of evidence is smoking, and that's high for comedonal acne in mature women who are chronic smokers. Otherwise, it is low. So if you're a chronic smoker, female, advised to stop smoking. It will benefit you apart from acne also. Other higher prescription drugs, most commonly by steroids, but there are a lot of drugs. I will not be discussing drug-induced acne, maybe in some future video, but most of the time steroids, anti-tubercular drugs, these are all drugs implicated for drug-induced acne. One important to understand is in drug-induced acne, you will have monomorphic acneiform lesions. All the lesions will be similar in morphology, while in acne vulgaris, you may have different morphologies in the same patient. So here we have anabolic steroids. Seasonal factor is a high strength of evidence. Otherwise, all of the evidences are towards the lower side. Okay, so let's start with the meat of the video, the major chunk of the video. Now, if you get a question that we have to write a short note on pathomechanism of acne, I would advise you to divide your answer into 5 points. If you remember these 5 points, you will easily write pages and pages on pathomechanism. And if you learn the pathomechanism for acne under these 5 headings, you'll be easily remember what is happening. So first is follicular hyper-keratinization. That means increased keratinization of the follicular or the hair apparatus. Second is hormonal influences on the hair, sebum, and skin. Third is inflammation. Fourth is Cutibacterium acnes. Now, this is the new name for Propionibacterium acnes. So now you don't have to say Propionibacterium acnes. You have to use the term Cutibacterium acnes. Okay. And fifth is neuropeptides. Most important are the first four for the mechanism of acne, and neuropeptides we'll just discuss because the newer evidence suggests the good and important role of neuropeptides in the pathomechanism of acne. So let's start with the first topic, the follicular hyperkeratinization. Remember that microcomedo is the precursor of the lesions. Precursor of any acne eruption is microcomedo. We know that the pathognomic lesion of acne is comedones, okay? And if comedone is very, very small, we term it as microcomedo. Microcomedo occurs at the level of infrainfundibulum, okay? Just below the opening through which the hair comes out onto the skin. Just below that, you have the site of development of microcomedo. So what happens in microcomedo? We have corneocytes or keratinocytes that accumulate. Okay, and why are the keratinocytes accumulating? That is because the follicular keratinocyte proliferation rate has increased. What do we mean by that? Now let's just say that this is the hair shaft. Okay, and you have the hair coming out. Let's rough diagram. Okay, so if and this is lined by keratinocytes. Okay, this everything is lined by keratinocytes. So if the keratinocytes start proliferating a lot, this will lead to blockage at the infundibulum level, and that will cause a microcomedo formation. Additional thing is the corneocyte cohesiveness. That means the stickiness of keratinocytes. So they are more sticky. So they are not easily shed off. And because of these two major reasons, you have blockage at the infrainfundibular area, formation of microcomedone. So because of this, you have microcomedone. Now, this microcomedone becomes an hyperkeratotic plug. That means an increased keratin plug. It plugs the opening. It stops the opening, blocks the opening, and this creates a bottleneck phenomena. So what is bottleneck phenomena? So it's like a bottle, oddly shaped bottle, but you understand what I'm getting at, okay? So this area becomes very narrow because of the blockage. The keratin is not able to exude outside. It's not able to get out of the follicular area, follicular depression, and this leads to blockage. And then this entire area gets filled with keratin, and it forms a comedone. Okay, so a microcomedone here, microcomedone at the level of neck, and then eventually it becomes a large comedone. Now, in many articles, they implicate interleukin 1 alpha and toll-like receptor activation as the first trigger points for microcomedone formation. So, if any question comes, what are the trigger points for microcomedone the formation? You will start with the corneocyte properties like increased proliferation of follicular keratinocytes and increased corneocyte cohesiveness, which might be triggered by interleukin 1 alpha and toll-like receptors activation. Okay, let's move forward. So here just a biopsy picture or a histomicrograph of a follicle, and this is the, let me just change the color. This is the infundibular, and below that you have the infrainfundibular area. And if you can see that this here is a sebaceous gland. Can you see this sebocytes? So this whole are the sebaceous gland, and where they drain, just distal to that you have the infrainfundibular region, and that is where the microcomedone forms, and it blocks the opening of this follicular apparatus. Now, after blocking of the opening, the keratin keeps on accumulating, and that accumulation leads to destruction of the apparatus, leading to inflammation, and that is how you get the inflamed acne lesions. How exactly it happens, we'll discuss in the subsequent slides. Okay, so let's move forward. Now, this diagram I've taken from Bologna. It's a very good diagram. Of course, Bologna is a book that has great schematic diagrams to understand the disease process. So I've given the reference here. Okay, it's at page 588 of the fourth edition. If you want, you can just go through the page and find out, look at the whole picture. But we'll discuss stepwise the formation of comedones. Okay. So earlier, what happens is there is hyperkeratosis and increased corneocyte cohesiveness in the upper sebaceous follicle, which leads to microcomedone formation. So here you have the infundibulum, then you have the infrainfundibular area, then you have the sebaceous lobule or sebaceous gland, and the entire hair. Because of increased corneocyte adhesiveness, this area gets blocked. So that's the first step which leads to the formation of early comedone. Let's move forward. Now, in later comedone, the second stage, you have accumulation of shed keratin. Now, the keratin which is being formed here will not be able to get out of the hair follicle and will accumulate. Okay. So shed keratin and the sebum, which is the secretion by sebaceous gland, they will get accumulated inside the follicle. And this will lead to a formation of whorled lamellar concretions. What do you mean by whorled? Whorled is like this, multiple layers circular. So this is known as a whorled appearance. Okay. So a whorled concretions or hard substance which is uh, which is shaped like onions, multiple layered structure. Comedone may be closed, in which the comedone is very, it's the follicular opening is okay, and the comedone is lying beneath the opening, then it is a closed comedone. If the opening is open, if the follicular opening is open and you can see the comedone with your naked eye, then it becomes an open comedone. Okay, so comedone may be closed, no obvious opening, or open if the follicular opening is dilated and the plug is visible to the environment. It's open to the environment. And when when the plug is exposed to the environment, the oxidized lipids turn the color to black. Oxidized lipid and melanin. So that is why open comedones appear black, while closed comedones are just beneath the skin. Okay, and if the comedone is very deep, very deep seated comedone, then it is known as a submarine comedone. Okay, submarine comedone. Like a submarine is below the water, it's very deep inside. So submarine comedone is also a deep seated comedone. Okay, let's move forward. Now the comedone has been formed. There is accumulation of keratin. All these things have happened. Now the inflammation will start. So here the book mentions Propionibacterium acnes, but now the name is Cutibacterium acnes. So there's proliferation of Cutibacterium acnes, and Cutibacterium acnes resides on the skin and on the sebaceous gland. So Cutibacterium acnes is actually a commensal organism which normally resides in the sebaceous gland and the follicle. When the follicle gets blocked, there's increased proliferation or increased multiplication of Cutibacterium acnes and the population rises. When the population rises, you will have increased inflammation and increased microbicidal activity. Now remember, all the commensal organisms living on our skin are responsible to limit the growth of pathogenic bacteria and organisms. Okay, but after a certain limit, if the commensal organisms are growing and they have crossed a threshold, then they themselves can become pathogenic, and that's what happens with Cutibacterium acnes. Okay, so Cutibacterium acnes proliferates and upregulates innate immune responses via toll-like receptors. Remember, toll-like receptors were the primary inciting factors in comedo formation. Now these get more and more activated. There's mild inflammation. In early stages, neutrophils will come, and subsequently they will be replaced by lymphocytes, like whatever happens in normal inflammation. Okay, and when this blockage is so much so that it causes an inflammatory destruction of the follicle, if that starts to happen, your sebaceous gland will atrophy. Now it's not healthy. Now it's inflammatory acne. Clear? So just stay with me. Microcomedo formation because of increased cornocyte adhesiveness and proliferation. That comedone will lead to a blockage of the hair follicle and keratin accumulation. This will lead to inflammation and proliferation of Cutibacterium acnes. Cutibacterium acnes will activate the innate system. There will be increase in inflammation, and sebaceous gland and follicular atrophy will happen. Clear? Let's move forward. Now you're able to understand the story, how we are progressing from increased keratin plug now to inflammation. Let's move forward. So when the inflammation is severe and the destruction of the follicle apparatus happens, what it leads to? It leads to formation of a nodule or a cyst. Now you have nodular acne or nodulocystic acne, which is the end stage of inflammatory acne. There's marked inflammation, and that's mainly because of T lymphocytes. And if there's marked inflammation, eventually it will lead to scarring. Wherever there's inflammation, there will be scarring. And then you have the end stage scarring seen in acne, or you have severe grade 3 inflammatory acne or nodulocystic acne. One of an important indication of using isotretinoin. Now this is the same picture that we have discussed in the previous 4 slides, and this is from Bologna, page 588. So it's a good picture that shows you the progression of starting with the comedo formation. This is the comedo formation. Then there is plugging of the follicle. Then there is increased inflammation, and then there's destruction and scarring. So that is how you have to layer your answer to explain more about the follicular hyper-keratinization leading to acne formation. Okay. So now we have discussed the first step of acne formation, which is follicular hyper-keratinization. Let's go towards the second step, hormonal control. Now, from birth to the first year of life, LH, which is the luteinizing hormone, is responsible for the production of testicular testosterone. Okay. Now, testicular testosterone means testosterone which will eventually comes from the testes, but remember that will happen during the puberty. Okay. This testosterone is not formed by the testes, it is formed by the androgens by fetal zone in adrenals. So in adrenal gland, let's say this is a poorly shaped kidney, and then you have adrenal gland. This adrenal gland will have a little portion devoted to production of androgens. And this little portion is known as a fetal zone because it was present in the fetus. It was responsible for production of steroids, sexual steroids hormones in the fetal time. Okay. Now this is still left in the first year of life and will gradually decrease, gradually regress over the first year of life. But during that time, it will still produce androgens under the influence of luteinizing hormones. The hormones will then gradually decrease till you reach adrenarche. Okay, what do you mean by adrenarche? Adrenarche means reactivation of the adrenal glands and the other sexual glands to produce sexual hormones. Okay, so this is, I think adrenarche is the first, I'm not entirely sure, but I think adrenarche is the first step of puberty, first stage of puberty. So that is how that's in the starting first year of life, you will have development of androgens under the influence of LH. Okay, so that is why acne in the first year of life either can be due to passage of maternal hormones, or it could be because of overactivation of this fetal zone of adrenals. Okay. In the first 7 to 8 years, or at the age of 7 to 8 years, when you start to develop adrenarche or the maturation of the hormones, the adrenal testosterone and DHEAS, which is dihydroepiandrosterone, is responsible for sebum production and will eventually lead to acne. So that is the age at which acne will start, 7 to 8 years of age, because of maturation of adrenals. Estrogen initially antagonizes testosterone and inhibits the pituitary gonadotropin and also gene inhibition. So these three ways are the reasons of inhibition of acne on estrogen. So that is why hormonal acne improves on OCPs, on estrogen containing OCPs, because estrogen antagonizes or acts opposite to the testosterone. How does it act? It is the hormone responsible for the reverse action, which are opposite to that of testosterone. It also inhibits pituitary gonadotropin as a form of negative inhibition, negative feedback loop, negative feedback loop, and gene inhibition, because any hormone which increases would try to limit its production as a form of negative feedback loop. So that is how estrogens help in acne. Let's move forward. Now, sebaceous glands are very responsive to androgens as compared to other hormones. Okay, so when there is sebaceous gland activity, that activity is significantly increased under the influence of testosterone and other hormones, but majorly because of testosterone. And in that, you have DHT, which is the most potent stimulator of sebaceous gland. Most potent. Okay, other factors like neuropeptides also lead to sebaceous gland hyperactivity, but we'll discuss neuropeptides in the end of the video. Androgen receptors are present at the basal layer of sebaceous gland and the outer root sheath of the hair follicle. So these are the areas where androgen receptors are present. They get activated by androgens, leading to more sebum production, more sebocyte activation, and that is why you have increased oiliness, increased inflammation in hormonal control. Sorry, hormonal acne. You will see more of an inflammation in hormonal acne as compared to more of comedones. Okay, so mostly it is the inflammation and the sebum production which is increased in hormonal acne. So you see more of inflammatory acne, let's say in females, because in females, with every menstrual cycle, you will have a spike of LH initially, and that is why acne will start developing 7 to 10 days prior to menstrual cycle. Okay, because of the peak of LH. And when luteinizing hormone increases, it will increase the production of testosterone, and this testosterone will lead to hyperactivation of sebaceous gland and in the acne apparatus. And because of that, you have hormonal acne. Okay, so in patients of hormonal acne, if you have regular menstrual cycles, you will very rarely find hormonal disturbances. Their levels would be completely within range, but you will still have increased inflammatory activity. That is because of increased responsiveness of the pilosebaceous units. Okay, I don't get hormonal levels done if the menstrual cycles are okay and there are no other signs of androgenization, no hirsutism, no other signs of any adrenal markers are not there clinically. So I rarely get hormonal profiles done because I know they will be normal, but I will still have to give hormonal treatment to suppress this increased activity of the pilosebaceous unit. So this pilosebaceous unit, or majorly the sebaceous gland, are more responsive to testosterone and 5-alpha DHT, which is the most potent hormone. Now, DHT is potent androgen and will lead to increased follicular keratinocyte hyperproliferation. So this is the stage 1 of microchromato formation. So DHT and testosterone will increase sebum activity, increase sebocyte activity, and also it increases follicular keratinocytes. Okay. DHES is converted to DHT via the action of 7-hydroxysteroid dehydrogenase and 5-alpha reductase. Okay. Now, follicular keratinocytes, they have increased 17-hydroxysteroid dehydrogenase and 5-alpha reductase activity. When this activity is more in follicular keratinocytes, more will be converted DHES, more will be the conversion of DHES to DHT. So you get my point? Follicles have increased 17-hydroxysteroid dehydrogenase and 5-alpha reductase. These two enzymes are responsible for conversion of DHEAS to DHT, and DHT is a potent hormone. Okay, so if keratinocytes are increased in number, more will be the production of DHT, and if DHT is produced, it will lead to more follicular keratinocyte formation, and that is why we enter a vicious cycle or a positive feedback loop cycle. So A will lead to B, B will lead to A, and they will keep on increasing the inflammatory activity, and that is why you have difficult to treat hormonal acne. Hormonal acne do not respond that better to retinoids. They respond better to hormonal supplements or spironolactone sort of drugs. Okay. Now DHT has 5 to 10 times affinity for sebocyte, and it's its main hormone for sebum production. Okay. Other factors like linolenic acid, interleukin-1 alpha, and a follicular growth factor receptor 2, these are also present at the level of sebaceous gland. And they are responsible for inflammation. They are pro-inflammatory, not markers, but the presence of linolenic acid, interleukin-1 alpha, FGFR2, if they are increased in keratinocytes, they will lead to inflammation and subsequent follicular keratinocyte proliferation also. So that is how the increased production of follicular keratinocytes leads to inflammation. So let's start the third step in acne formation, which is the inflammation, or the inflammation as an effect. That means as a result of follicular hyper-keratinization. Okay, so let's start. So where have we reached in our story? The keratinocytes have increased, they have proliferated, they have plugged the area. Now the keratin is not able to exit the follicle. There will be accumulation of keratin, so much so that the follicle will rupture. So it starts with follicular rupture. When follicular rupture happens, keratin, sebum, Cutibacterium, acnes, and the other cellular material are released. They are released in the surrounding area, and when they're released in the surrounding area, there will be inflammation because now the immunity knows that something is there which is not supposed to be there, and there will be inflammation. Clear? So this is the effect of follicular hyperkeratinization. Inflammation can also be seen early, and that is evident from the fact of increased perifollicular CD4 plus T cells, interleukin 1 and interleukin 1 beta. So these cytokines are responsible for inflammation, and it has been found that patients who are prone to acne can have increased perifollicular CD4 T cells, interleukin 1, interleukin beta, before the clinical development of acne. So some people say that inflammation could be the starting step, not as an effect, but as a trigger. And we'll discuss inflammation as a trigger in the next slide. Okay. So when the inflammation happens, the first cell to arrive is neutrophils. Like in anywhere else you have inflammation, you have neutrophils. Now, early migration of neutrophils is responsible for cell destruction of the corneocytes, and reactive oxygen species, which they will release, and lysozymes, which will be released by neutrophils. So neutrophils is responsible for cellular destruction, reactive oxygen species, and lysozymes. When there is cellular destruction, eventually it will lead to pustular acne. Okay, pustules and separation, which is only pus formation. So you have an acne lesion, and when there is increased destruction, you will have a pus formation. You won't be able to see white. You will have pus formation. And this will lead to formation of pustules. So when inflammatory activity is severe, you will have pustule formation. Okay. So in the early stages of inflammation, you have neutrophils, and gradually these neutrophils will be replaced by lymphocytes, majorly lymphocytes at a level of late inflammation. And then you will have inflamed papules, nodules, and cysts, which are the severe form of acne. You have nodulocystic acne. Okay. So initially it starts with neutrophilic inflammation, and then it will gradually lead to a lymphocytic form of inflammation, where you will have more nodules, cysts, significant inflammation. Now remember, neutrophils are responsible for the initiation of inflammation, so that the initial attack is carried by neutrophils, but lymphocytes are responsible for persistence of inflammation, so that in chronic inflammatory disorders you see more of lymphocytes, while in earlier stages of inflammation, you see more of neutrophils. Okay. Now, inflammation as a trigger, that means as the starting event of acne. So we have said that interleukin 1 can be seen in perifollicular area in people who are prone to acne formation. And interleukin 1 is responsible for inducing inflammation keratinocytes. So before the acne or microcomedo has started forming, you have increased interleukin 1 in the perifollicular area, leading to inflammation. You also have upregulation of TNF alpha, and if you have been following my videos and seen that video on pathomechanism of psoriasis, you will know that TNF alpha is the initiator of all kind of inflammations. Okay, here TNF alpha increases inflammation. It also increases lipogenesis, that means formation of more lipids in the sebocytes. So TNF alpha is increasing inflammation and increasing oil production by sebocytes. Okay. The COX-2 enzyme, the cyclooxygenase 2 enzyme, is also increased in acne, and it is responsible for inflammatory mediator formation and increased sebum. Now, COX-2 is responsible for prostaglandin leukotriene mediated inflammation. So, it is also increasing inflammation. Sebocytes also express other pathway of leukotriene synthesis, and again, this will lead to inflammation. So, all these let me just write again. Yeah. So all these four factors are actually increasing the inflammation. And many of the times in patients who are prone to active form eruption, you will see these factors starting earlier to disease. So inflammation can also act as a trigger. It can also be the effect of follicular hyper-keratinization. You get my point? So it doesn't necessarily mean that an acne lesion will follow these steps one by one. Steps can be started together also. So inflammation can act as trigger. Just remember the headings and you will remember everything else. You can easily write how an acne is going to form. Now, there are other receptors also. Receptors for leptin, which is responsible for lipid induced inflammation. Substance P, which is a neuropeptide. Insulin like growth factors, which is mainly glucose, responsive to glucose. And these receptors are, as per many good articles, they're responsible for the dietary influence. Okay, so when you eat something, you will have increased expression of IGF-1. If it's more in lipids, then leptin, these all will increase. And because their receptors have been found in the follicular apparatus and sebocytes, because of diet, these kind of influences are seen in acne. Okay, let's move forward. Okay, so now we'll discuss the fourth parameter, which is the action of Cutibacterium acnes, the organism which is very importantly implicated in acne. There are other organisms also, but mostly Cutibacterium acnes has been implicated. So Cutibacterium acnes is a gram-positive, anaerobic or microaerophilic bacilli. It's a commensal organism. I've told you it lives normally in nearby the sebocytes and the follicular apparatus and somewhat on the skin too. Majorly, it secretes porphyrins, primarily coproporphyrin 3, and that is the usual, you could say, not function, but the usual lifestyle of Cutibacterium acnes. So, when the population is increased, it can lead to increased inflammation and activation of the innate pathway of immune system. Okay. Density does not correlate severity. It has been found that patients with severe acne might have near to near same amount density as compared to people with non-severe acne. So this is not, the density is not proportional to severity. Okay, so and why is that? Because acne is a multifactorial inflammatory disorder. You don't have to blame just Cutibacterium acnes. Other factors are also playing a role. So the density does not correlate severity. Okay, so if you're adding antibiotics in your regimen, make sure you couple it with a non-antibiotic modality also. Best action is to couple it with benzoyl peroxide or retinoids as per your convenience. Now, Ribotax 4 and 5 are mentioned to be more acne prone. This is, I think, from Bologna or Rooks. I don't exactly remember the reference, but in one of the book it is there. And this could be a good quiz question. Okay, good quiz question from the textbook. Now, more the Cutibacterium, more is the inflammatory response because more bacilli can activate the immunity. Now, Cutibacterium acnes has also been implicated to form a biofilm. What is biofilm? The secretions of the bacilli forms a scaffold, a framework, and that framework covers the bacilli and inhibits the bacteria's destruction. And this leads to persistence of bacterial inflammation, and that is what essentially is a biofilm. Mostly it is seen in fungal infections, but Cutibacterium also forms biofilm. You can see biofilms in any organisms. Cutibacterium is also one of them. And because of formation of biofilm, you have persistence of infection in acne. Let's move forward. Now, Cutibacterium releases lipases and other chemotactic factors and enzymes. So lipases will destroy the lipid-containing areas, majorly sebaceous gland. Chemotactic factors will cause inflammation. What do we mean by chemotactic? These are chemicals which cause the inflammatory cells. So it will lead to increased inflammation, and enzymes which will lead to comedone destruction and the rupture of the surrounding follicular area. So because of these three factors, you have rupture of comedone, you have inflammatory cell stimulation, you have pro-inflammatory mediators release and reactive oxygen species. So all of this is released by Cutibacterium acnes. Okay. Toll-like receptors. Remember again, toll-like receptor could be the inciting factor for microcomedo. Toll-like receptor 2 recognizes C. acnes. Okay, it also recognizes interleukin-1 alpha, and because of this, it will lead to secretion of different interleukins. Four of them I'm mentioning here. Interleukin 8 is responsible for neutrophil recruitment. Remember, neutrophil comes in early stage of inflammation, and this is called by interleukin 8. It will also lead to lysozymes and will lead to tissue destruction, which will eventually lead to formation of pustules. So that is how neutrophils form pustules. Clear? We have discussed that in the previous slide, how neutrophils cause pustules. Interleukin 12 is responsible for activation of Th1 response. So more inflammation. TNF alpha stimulation, which is again more inflammation. We have discussed that in the previous slide. And matrix metalloproteinases. This will lead to tissue and follicular destruction. Now, remember that MMPs or matrix metalloproteinases are responsible for collagen destruction. And what is the major protein in our dermis? It is collagen. So when collagen destruction happens, you are essentially destroying the dermis. And whenever there's dermal destruction, there is more scarring, there is more inflammation. And that is why the activation of MMPs leads to a severe acne. And that is all because of toll-like receptor 2. Okay, so again, repeat after me. Activation of toll-like receptor 2 by C. acnes and interleukin-1 alpha leads to interleukin 8, which will cause neutrophils, interleukin 12, which will lead to Th1 response, TNF alpha, which will lead to inflammation, and MMPs, which will lead to destruction of the dermal tissue. Clear? These 4 points, remember these 4 points, and you will recognize how Cutibacterium acnes can lead to worsening of acne. One additional point here I would like to mention is toll-like receptor 2 is also responsible for steroid-induced acne. I think this is what this one question I got in one SR exam, I think. So steroid-induced acne is mediated by toll-like receptor 2. Let's move forward. Now, the fifth mechanism is the activation of inflammasomes. Now, this is one thing which is new in immunity, in dermal immunity, inflammasomes. Now, there's activation of NOD-like receptor protein 3 or NLRP3, and this leads to formation of inflammasomes. Just remember as of now that inflammasomes leads to more inflammatory destruction. Inflammatory destruction. Okay, so more inflammasomes, more inflammation, more destruction. Clear? Sixth is the Th17 response. And if you remember our video on psoriasis, Th17 means inflammation. So there's also more inflammatory damage. Seventh is monocytes. Under the action of Cutibacterium acnes, the innate immunity gets activated. Okay, innate immunity gets activated. And if you wish, there are multiple articles to read about the activation of innate immunity by Cutibacterium acnes. I request you to go and search for them. It's a very good story how C. acnes activates innate immunity system. So when that system is activated under the influence of C. acnes, monocytes get modified to one of these two kinds of macrophages. One is CD209 plus macrophages. That macrophages can be increased by retinoid and they phagocytose C. acnes. Okay, so activation of innate immunity by C. acnes. So what happens is the cells of innate immunity will come at the site of acne. They will recognize C. acnes and then they will modify themselves. They can modify themselves in CD209 plus macrophages and they will eat C. acnes. That's the normal response. Okay, CD1b plus dendritic cells. We all know that dendritic cells are actually antigen presenting cells. They will present antigen to T cells. So dendritic cells will activate T cells and these T cells will release pro-inflammatory cytokines leading to inflammation. So normally, understand this concept very clearly. Normally, inflammation is a process by which you destroy the bacteria or pathogen. During that destruction, there is collateral damage of surrounding areas, and that is why inflammation is beneficial and harmful both. Here, in this case, the activation of monocytes to form dendritic cells and further lead to inflammation is to destroy C. acnes. But if this activation goes uncontrolled or more than a certain threshold, you have inflammatory destruction leading to inflammatory acne, pustules, nodules, cysts. So you understand my point? Anything which is helpful after a certain threshold will lead to destruction. So you understand? So we have read about majorly seven types of triggers that C. acnes leads to acne formation. Okay, so you have the toll-like receptor 2 activation leading to IL-8, TNF alpha, TH1 response, and matrix metalloproteinases. Then you have inflammasome activation by nod-like receptors. You have increased Th17 activity. You have monocyte formation leading to dendritic cells, leading to pro-inflammatory cytokines. So you have seven triggers how C. acne causes acne vulgaris. So if you get a short note on Cutibacterium acnes and its role in acne formation, you start with C. acnes. Tell some properties, microaerophilic, bacilli. You tell about how it is commensal, it is found near the sebaceous gland, skin, and the follicular apparatus, how the levels are increased, how these increased levels activate innate immunity, and how innate activation immunity leads to inflammation, how are the other triggers of inflammation leading to acne. You can write easily short note or a large note, or you can answer viva questions. How is C. acnes implicated in acne formation? Clear? Let's move forward. So here is just a picture that I've taken from an article. I'll put the reference in the description so you can go and read the article. So this black urchin-like legend is for C. acnes. So here it is C. acnes in the skin, in the follicular apparatus, and near the sebaceous gland. I should change the color. I don't know which one is visible. Yeah, yes. So you can see C. acnes are near the sebaceous gland, in the follicular apparatus, okay, and the infundibulum in the skin also. The red one is C. epidermidis. C. epidermidis is also a commensal organism. C. epidermidis grows so that Staph aureus cannot grow. Okay, just remember this. Corynebacterium is the green flagellated one. Staph aureus is the this one, pink one. Okay. And Malassezia furfur is this one, small little oval brown. But we have to concern ourselves with the action of C. acnes and staph epidermidis. So this is the normal pilosebaceous unit. Okay, I'll just remove all the markers. So this is normal pilosebaceous unit, and you will see all the commensal organisms around it. Clear? Let's move forward. Okay. So in the last slide, we saw the normal commensal organisms, and here we'll see the acne lesion. So in acne lesion, you will see that. Let me change the color. Yeah, this C. acnes is increased in number. You can see the proliferation. You can see the atrophy of the follicle. You can see that in the skin, the C. acnes is also increased. You can also see that there is blockage of the follicular infundibulum. You can also see the activation of toll-like receptors. Okay, and this fire-like thing is because to show inflammation. So you can see the inflammation is also increased. So when you move from a normal hair follicle, normal pilosebaceous unit, to an inflamed pilosebaceous unit, you will see increased proliferation of C. acnes. Okay, you will see follicular blockage, you will see atrophy of follicle, you will see increased inflammation. So, and that is why these acne lesion is, starts as an inflammation, starts as a blockage, and you have the increased population of C. acnes directly implicated in the process. Okay, so now we'll come to the fifth part, the neuropeptides. Okay, so neuropeptides include a lot of different chemicals, different peptides, proteinaceous chemicals. So some of them are corticotropin releasing hormone. Just a second. Yeah. So some of them is corticotropin releasing hormone, melanocortins, beta endorphin, vasoactive intestinal peptide or VIP, neuropeptide Y, CGRP, just name it. Okay, neuropeptides, you just have to know about them so that you can write 2-3 lines and the examiner should be happy. No guarantees, but examiner should be happy. Now, these are all inflammatory mediators. They will increase inflammation. A good potent is substance P. And if you have gone through our video of pathomechanism of pruritus, you will understand how much important substance P is regarding inflammation. Now, substance P in the context of acne increases sebum, increases sebocyte size. So, size of the sebaceous gland and the increased production of sebum is also increased under the action of substance P. There's neuropeptides also increase adhesion molecules, which are responsible for calling out the inflammatory cells and attachment of inflammatory cells at the site of action. So, if adhesion molecules are increased, such as E-selectin, the chances of inflammatory cells getting sequestered at the level of inflammation also increases. So, you get that point? If the adhesion molecules are more, the cells will come and attach itself at the follicular level. They will not leave easily, so the inflammation will be prolonged. And these are also implicated in role of diet. So multiple dietary factors like milk and milk products, whey proteins, high glycemic index foods, they have all been shown to increase neuropeptides. So when neuropeptides are increased, the inflammation and adhesion molecules are also increased. And because inflammation increase, you have increase in acne as a response to diet. Not every patient will have dietary influence on acne, but if there is a dietary influence, the major implicating factors are majorly neuropeptides. Okay, so in the previous slide, the previous part of the presentation, we have discussed the 5 steps of acne formation or the 5 major headings that you should remember while writing your answer. 5 steps are: step number 1, follicular hyper-keratinization, microcomedo formation. Step number 2, hormonal control. DHT is the most potent hormone. Okay. Step number 3, you have inflammation, both as an effect of acne formation and a trigger of acne formation. Step number 4, C. acnes, activation of innate immune system, increase inflammation. Step number 5, neuropeptides, majorly substance P, CGRP, corticotropin releasing hormones, and they have a major role in increasing inflammation and sebum production and the role of diet in acne. Clear? Just remember these 5 findings, remember some of the points. You can easily write pages and pages on the pathomechanism of acne vulgaris. So in very brief manner, we'll discuss the histopathology of a comedone. It is, I think, hardly 2 slides. So I just wanted to discuss because now we have discussed the pathomechanism. We know what is happening. It's a good idea to see what is happening. So in the early stages, you have microcomedones with mildly distended follicle and a narrow impacted or closed opening. There is prominence of the granular layer. Clear? Sebaceous gland may be atrophic or absent. This we are talking about if the inflammation has gone in late stage. Okay. There is mild perivascular perifollicular mononuclear infiltrate because the inflammation is now started. In late stages, the follicles may rupture. We have told you that release of matrix metalloproteinases, lipases by C. acnes, the follicle ruptures. There is marked inflammatory response in late stage. You can even see foreign body granulomas. And in end stage, when the inflammation goes away, scarring can happen. The scarring is important, and that happens when the inflammation goes unchecked. When there is significant tissue destruction, you have scarring. Okay. We just discussed about two comedones, closed and open. In case of closed comedones, so this is the skin and this is the comedone. It is covered by skin, so it is a closed comedone. Clear? So in closed comedone, there is more distension. There's a compact cystic structure because it is underneath the skin. There's more eosinophilic keratinaceous debris, hair, and numerous bacteria. These are all collected into a small space, forming a closed comedone. Okay. In open comedone, this follicular opening is open, and you can see the black oxidized keratin and melanin to form an open comedone. Okay. So open comedone, you have a broad expanded follicular ostia. In closed comedone, you have closed ostia. In open, you have expanded open ostia, and there's distension, the dilatation of follicle in open comedone. So this is the histopathology of open and closed comedones. So in this photomicrograph, you can easily see an impacted eosinophilic keratinaceous material filled with keratin plugging, and that is actually a microcomedone. Along with that, you can see the surrounding destruction of the follicular apparatus, and you can see the inflammatory infiltrates. Can you see this? This is all inflammatory infiltrate. Okay, this is a vessel, so you can see perivascular inflammatory infiltrate. Okay, so you can see the microcomedone, destruction of the follicle, and surrounding perifollicular infiltrate. So this is the small biopsy which I wanted to discuss. Maybe in the future when I'm discussing dermatopathology, I personally like dermatopathology. I don't know much of it, but I always like to see the slides and learn. So if in future, if I have time and all the good topics are finished, maybe we'll start a good discussion on dermatopathology, and then I'll be able to better explain about what all I see in the slide. But just remember the microcomedone, the perifollicular inflammatory infiltrate with destruction of the hair follicle. Clear? So with that, and with this video, we have covered 4 textbooks and 3-4 extra good articles regarding the pathomechanism of acne. These are the references, but trust me, if you have gone through this video properly once, you won't require these references. So I've covered Rooks, I've covered Fitzpatrck, Bologna. Bologna is best in my opinion, of course. If you want to know about newer things in etiopathogenesis of and treatment of acne, this article is good. It's brief. It's just a good summary. And what is new in the pathophysiology of acne and overview will tell you about the inflammatory markers, mediators, cytokines, what all inflammation is happening as a part of pathomechanism of acne. There are multiple other articles. I would suggest you go and find articles regarding the activation of innate immune system by C. acnes, a very good read, and go through it. And once you understand what actually is happening, and remember, if there's follicular hyper-keratinization, you see more of comedones. If there's more inflammation, you see more of inflammatory acne. And if you have inflammation, you start an anti-inflammatory agent. That could be an antibiotic or omnicortin or benzoyl peroxide that also has anti-inflammatory effects. And if you have comedones, then you will rely more on retinoids. Okay, so you have to balance these drugs if you know what exactly is happening in what stage of acne. Clear? So with that, This video is finished, and we have covered this time more of a textbook academic topic about the pathomechanism of acne. I apologize I could not release this video on Saturday. I was having some issues, but now I think these are sorted, and Sunday is a good enough day to enjoy academics. If you don't want to enjoy it, see it on Monday, I don't care, but see it once, and your concepts about pathomechanism of acne should be clear. Okay. If you have any doubts, just email me. But as I've said earlier in last week's video, that I've been receiving a lot of emails, so they tend to get submerged in my inbox. A good idea would be to comment your doubts, questions, any queries, suggestions. They can be academic suggestions, non-academic suggestions in the comment section, so that other people can read. Maybe they have the same doubt, and then they will be answered, because we will discuss your questions in the comment section, and they can go through that discussion. Maybe their doubts will be answered. So help others. That is how you learn. You help others so that they will help you, and that is how you learn new things. You cannot learn dermatology even if you live for 500 years. So it's better to learn from each other. That's the point that I'm trying to make. So with that, we'll finish this week's video. Adios. And by Sunday, you might have enjoyed your weekend, but still enjoy the rest of your Sunday. Bye bye. Busy week.